Ladies and gentlemen, welcome to the high yield questions of ophthalmology for your coming examinations, and leading you through this minefield of difficult questions is your friendly neighborhood ophthalmologist, yours truly, Sashwat. Welcome. We will make it short and sweet, so just watch and see what you can imbibe from. And here we have for you the most famous pair of eyes in the world. We talk about eyes, and the most famous pair of eyes in the world is that of Mona Lisa. Very well. Let's look at the first question. It says a 15-year-old boy presents to a clinic with difficulty in coordination of movements and abdominal pain. So he has some abdominal pain and movements. On further examination, copper deposition in a ring forms in the cornea, most likely diagnosis. This should not be too difficult for you. Remember, copper deposits in a ring around the cornea combined with incoordination of movements leads to only one diagnosis, and that is keratitis, Huntington's disease, Wilson's disease, or neuroblastoma. And I'm sure you all answer this is the Wilson's disease. And the copper ring that you see here is called the Kayser-Fleischer ring. It's not. We all know that. That is deposited on the cornea. On the descemet minimum of the cornea is the KF ring, which you can see here. Can you see this? This has been arrowed here. And this brown ring that you can see here, this brownish ring, and you see the brownish ring, this is not always evident. Remember, it's not evident on torchlight. It has to be in the slit lamp examiners. That is why you will often find that gastroenterologists often send these patients to ophthalmologists and requesting us to locate the KF ring, because they can't see it in torchlight. They request the ophthalmologist to see the KF ring on the slit lamp and confirm their diagnosis, which is a Wilson's disease. So the answer here is KF ring and Wilson's disease. Please remember not to confuse this with the Fleischer ring of keratoconus. Okay, Kayser-Fleischer ring is not the same as Fleischer ring. Sashwat ray is not the same as Lisa ray. They are both rays, but they are different. So that way, Fleischer ring is keratoconus, Kayser-Fleischer ring is seen in Wilson's disease. Very well. A child presents to you with proptosis, pain and loss of vision. On examination, the following picture is seen. What is the most likely diagnosis? And the picture is very, very typical. Look at that proptosed eye, inflamed eye, conjunctiva spilling out. This is a very dangerous looking eye. And what is it? Is it orbital cellulitis? Is it a sty? It's a preseptal cellulitis, or is it a blepharitis? And the answer, I'm sure you all got it, is orbital cellulitis. So remember, orbital cellulitis is infection of the orbit. So what happens is the infection of the orbit just behind the eyeball. Okay. So remember, it's not the eyeball itself that is inflamed. It's the structure behind the eyeball. Okay. Things like the fat, the fascia, the muscles. So these has got it. And remember, preseptal cellulitis and orbital cellulitis, how to differentiate? There is a typical barrier here called the orbital septum. Orbital septum is an area of demarcation. If it's inflamed in front of the orbital septum, called preseptal cellulitis. If it's behind the orbital septum, it's called orbital cellulitis, and it appears to us mostly in children. It's mostly in children, where the most common cause is ethmoidal sinusitis. It could be some dental infection also. It could be some infections from any of the sinuses, the most common being ethmoidal sinusitis. The infection spreads to behind the orbit, and the child presents to us in proptosis, chemosis, which means conjunctival edema, loss of vision, and he's unable to move his eyes. His ocular movements are lost. Okay, this is typical orbital cellulitis. It's a very dangerous infection, and we often have to admit the patient to the hospital and start intravenous antibiotics. Okay, so this is orbital cellulitis, and this is what it looks like. As you can see here, the reddish area. This is orbital cellulitis. Preseptal cellulitis you can make out because it looks more in the eyelid. The inflammation is more in the eyelid rather than the orbit, because the orbital septum is, remember, differentiating between preseptal cellulitis and retro, which is orbital cellulitis. So this is a very dangerous infection, and particularly it may lead to an extremely dangerous condition called as cavernous sinus thrombosis, where usually bilateral. Very well. Patient complains of inability to drive in the night, particularly in rainy and foggy nights. But the vision is 6 by 6. Dear me, if he has a good vision, why does he have problems in driving at night? We shouldn't have, isn't it? But there is. And the problem is, which visual test should be performed here? Should I do a color vision or a visual field, intraocular pressure, and contrast sensitivity? Okay, now here they all seem very good choices to me. Color vision, but remember it's dark, it's night, so it doesn't matter much. Visual field is important for driving, but remember the question is rainy and foggy nights. The answer here is contrast sensitivity. You know that this is, we can see it clearly here, ladies and gentlemen, you can see the fog here enveloping the railway line here. Remember that contrast sensitivity is probably the most important visual quality that is important for us in day-to-day life. You see, visual vision or visual acuity measures bright letters, dark letters on a white background. This is not what most of our day-to-day activities are. In day-to-day activities, we have to drive in rain and fog and snow. We have to pour coffee in a black mug. So that whenever you have problems of lighting, then we need a condition known as contrast sensitivity. This contrast sensitivity is measured by a Pelly-Robson chart, which we have talked about before also. You can see slowly the letters, they become less and less dark until at a certain point you will be not able to see the letters at all because they merge with the background. Okay, so this is called as a contrast sensitivity and is reduced in certain conditions, particularly cataracts, glaucoma, macular degeneration, and optic neuritis. So often there are multiple conditions where I have loss of contrast, where the vision may be 6/6, but still the patient is not able to distinguish the objects from its background. Okay, this means that they may have a problem of contrast sensitivity, in which case we must check the Pelly-Robson charts. Kindly remember, contrast is always suspected when you are not able to distinguish objects from the background, as in typically as a foggy night or a rainy night. Very well. Then a mother brings a child to the OPD with complaints of watching blackboard with eyes half closed like this. Why on earth? Why on earth would they close their eyes? And you all very well know the answer. The most probable diagnosis could be myopia, hypermetropia, amblyopia, or an isometropia. And I'm sure you all know the answer. It is myopics. The myopics typically have this half-closed look, is it not? And you all know. And look at this half-closed look of this little lady who's squeezing her lids like this. And many of you do that actually while watching TV or even watching this YouTube presentation. This is a typical myopic gesture that they keep the eyes half closed. In fact, that is why it's called myopia. The word myopia comes from a German word called myopin, which means a person who keeps the eyes half closed. Why do they do that? They do that because by keeping the eyes half closed, the eyelids, they make up a slit, okay, and it creates a pinhole effect. And by improving the pinhole effect, by using the pinhole effect of the eyelids, they are essentially improving their vision, okay. So many of you, in fact, squeeze your eyes when you look at the blackboard or the whiteboard or the YouTube, and you're actually myopic who need glasses. Very well. In which condition is collagen crosslinking used here? That's a simple one. All of you should know that. And you can see here, this typical picture is bullous keratopathy, corneal dystrophy, keratoconus, or uveitis. The answer, as you all know, is keratoconus. A keratoconus condition where the cornea is conical like this. Remember, the two problems of keratoconus is first, that is conical, and second, the cornea is thin. Okay. And why is it conical thin? Well, because you rub your eyes so much. Remember, the single most important predisposing condition to causing keratoconus is rubbing your eyes. Many of you itch a lot and you rub your eyes incessantly, a thing which you should not do. And even if you do it, remember, never to rub the eyes with the knuckle. You must do it with the palm of the hand. As you press on the eye, it causes thinning of the cornea, leading to a condition called keratoconus. This is a progressive, non-inflammatory thinning and ectasia of the eyes, usually presenting in early teenage from around 20, 17, 18, 19, 20, until 30. And this collagen crosslinking, we call it C3R because there are three C's: corneal, collagen, crosslinking with riboflavin. Okay. So riboflavin, we pour riboflavin drops on this, and what happens? Patient lies down with the keratoconus, and there is this. We pour on top of the cornea. We keep pouring riboflavin eye drops, and this acts as a photosensitizer. And this particular, so you can see this is happening here, and this ultraviolet light from ultraviolet lamp being radiated onto the cornea, and this riboflavin acts as a photosensitizer, and together they increase the collagen bonds of the cornea. Okay, so the cornea is getting thinner and more steeper because it's soft. So by increasing the number of collagen bonds in the collagen, so the cornea becomes more stiff and resists further coning and stops the progressive keratoconus. So this is the latest modality. You should all remember, we call it C3R. It is the latest treatment for stopping the progression of keratoconus. Remember, it will not cure keratoconus because keratoconus, it's already conical. By doing C3R, you cannot flatten the cone, but at least you will stop it from further coning. This is also called as CXL, corneal crosslinking with riboflavin. So this was keratoconus. Which of the following is the most common ocular presentation of Marfan syndrome? And that's very important. Remember, Marfan syndrome. Is it keratoconus, retinitis pigmentosa, subluxation of lens, or retinal detachment? Remember, a lot of these conditions do occur in Marfan syndrome. There are a lot of ophthalmic manifestations of Marfan's, but the most common is the single most common is subluxation of lens. The lens gets moved, it gets ectopia. We also call it ectopia lentis. Remember, the other condition, the other word we can use is ectopia lentis, where the lens subluxates to a new position, not in its normal position behind the iris and in the patella fossa, but it moves to a different position. The most common position, remember, in Marfan syndrome is the supratemporal area. So the lens, instead of being lying exactly in the center of the pupil, shifts slightly superior and temporally to lie supratemporally. This is the most common location of the lens in Marfan syndrome, and the most common ocular presentation is subluxation lens. But you may have high myopia, you may have retinal detachment, you may have glaucoma. There are multiple other ocular manifestations of Marfan's, but the single most common, as you can see, hanging by a few threads, hanging on grimly to life, is the lens. You can see the lens, it is moved upward and outward mostly, and not in its normal position behind the pupil. This is typical lens subluxation, the most common ocular finding of Marfan syndrome. Let's look at this. Now, there's a new instrument here. Instrument shown in the image is used for which of the following clinical conditions? So take a look at the instrument, and you see when you look at this, it looks like a forceps or a clamp. But look at this ring-shaped thing that you see here, and that is the clue. Okay, that ring that you see is the sign that's the Collagen forceps. Because you pick up the Collagen, you all know what a Collagen is. Let me show you a typical Collagen forceps. It looks like this, isn't it? It looks like this. You see this ring? So what we do, we grab the Collagen. You know, Collagen is a chronic granulomatous inflammatory mass of the Meibomian glands. The Meibomian glands gets blocked and the secretions gets blocked there. So you land up with a lump in the upper eyelid, mostly the upper eyelid. It could be lower also, it could be upper also. Mostly it's upper. You can see this painless lump on the upper eyelid. This is the Collagen. This is because the Meibomian glands have got blocked, often due to oily skins. It could be psychosomatic also. So what we do, we take this clamp, and this ring is the sign, because we place this ring on top of the Collagen and we invert this and we make a cut like this and you cure it out. The treatment for Collagen is incision and curettage. Please remember, the best treatment, the ideal treatment, finally we have to do, it's called I&C. It stands for incision and curettage because you curate the secretions out, okay? And the ring helps you grasp the Collagen, and then we invert it and we make this cut on the underside of the lid so there is no scarring on the upper surface, and then we cure it. Remember, it's not I&D. Incision drainage, I&D is done in always when it is pus, okay? This is a purulent condition. This is not a pus. This is blockage of secretions of Meibomian glands. So it's I&C, which is completely different from I&D. So this instrument, as you can see here in more detail, is a Collagen forceps. You can make out by the single ring layer we use to grasp the Collagen in its entirety. Very well. In which condition is a lid retraction seen due to excessive sympathetic stimulation of the Mueller's muscle? Now, lid retraction, remember, the lid retraction goes behind like this. Excessive sympathetic stimulation of the Mueller's muscle is a lid retraction. Remember, congenital just the opposite. I mean, coatosis, the lid is drooping down. There's no lid retraction, just the opposite. It cannot be that. Myasthenia gravis, again, remember, myasthenia gravis, the commonest ocular manifestation is ptosis, because the LPS is the first muscle to get damaged in myasthenia. Legophthalmos is a partially opened eye, which means incomplete closure of the eyelid. The answer is Graves' disease, where it is the commonest ocular manifestation of Graves, remember, is lid retraction. Can you remember, the most common ocular manifestation of Graves is not, remember, it is not proptosis or exophthalmos with bulging eyes, but the most common is actually lid retraction. And the reason for lid retraction is because of the Graves' disease. It causes excessive sympathetic stimulation of the Mueller's muscle. You know, Mueller's muscle is one of the lid retractors. It pulls the lid back and causes lid retraction like this, which is the most common ocular manifestation of myasthenia. And you can see the multiple ocular signs of Graves' disease. You can see a lid retraction here, increased show. You can see the upper lid retraction here. You can see the conjunctival redness and chemos, another powerful sign. Eyes become red very easily. The lateral flare of the eyelid, where it becomes a little more angular like this, and the thickened brows are seen again in hyperthyroidism. The lower lid retraction, and particularly the puffy lower lids, is a very important sign. Puffy lower lids can be signs. These are multiple signs of thyroid, and I can tell you that it is very easy for us ophthalmologists to diagnose thyroid looking at the eyes. Okay, so please remember here the reason for the lid retraction is given to you here: excessive sympathetic stimulation by the Mueller's muscle, pulling the lid away and causing the lid retraction. But there are multiple signs of Graves' ophthalmic signs which you can see here. Very well. What is the best next step in management in a 5-year-old boy suffering from chronic epiphora? Remember, epiphora means the tears are draining down the lids, the lower lids, and this is epiphora. Remember, a similar term is called lacrimation also. Lacrimation actually, if you look at it strictly, means overproduction of tears. Epiphora is tears falling down the cheeks because of blockage in the ducts that lead to the drainage of the lacrimal apparatus. So, it's a child, a 5-year-old boy, which suffers from chronic epiphora. There is a laryngeal probing, is a dacryocysterinostomy, which is for short form, the DCR, the tarsal plate fracture, or the lacrimal sac massage. Now, this is a very important question. This particular algorithm is there, and you must remember this algorithm because it's important for the timing. So, a 5-year-old, remember, this condition is basically a congenital dacryocystitis. Okay, congenital dacryocystitis or congenital nasolacrimal duct block. So, congenital dacryocystitis, you have it here, and look at that. You diagnose this by the 3 classic signs of epiphora: is watering, you have discharge, and you have crusting. So, you can see the dried up discharge, which is the crusts, which is the discharge, and see the watering. And about 5% of newborns have this. Okay, newborns have this. So, often they present. Usually, they get automatically, they get spontaneously canalized, recanalized. The basic reason is that the valve of Hasner, okay, there is a valve of Hasner. This is a valve which opens in the inferior meatus and it is not canalized. That means it is not patent, so it is blocked. So, the tears they are not able to go down the normal pathway and go to the inferior meatus. So, this water, these tears, they get dammed up and they get stagnant in the lacrimal sac where they get infected, and this infection is visible to us as excessive watering, crusting, and discharge. So, this is NLDO, and see there we have a typical algorithm which you must remember. Remember, the management of congenital NLDO is lacrimal sac massage. First 6 months usually we do regular massage. So, what you do, you put your fingers like this, or like gently. Remember, these small kids, they're newborns, you cannot push them too hard and crack the nasal bone here, the delicate nasal bone here. So, particularly the males should be careful in putting their thick sausage-like fingers here. So, we do not encourage the fathers. We tell the mothers with the delicate fingers, index fingers, and they put it here like this. If both eyelids are blocked, they put it like this, and gently but firmly you stroke down like this. This is called lacrimal sac massage. You put your fingers here, firm but gentle massage, stroke it 1, 2, 3 like that. Okay, so strokes like this is called lacrimal sac massage, and this works very well in the first 6 months of age because what we do by putting our fingers and pressing it down, we increase the pressure which pops open the valve. Okay, this valve is just on the verge of opening up anyway. So, by increasing the pressure, we pop the valve open and it opens up. So, this usually works very nicely, but only up to 6 months of age. And after 6 months of age, if it doesn't do, we can still do it for a few more months, but it doesn't work. Then we try probing. You put a delicate probe, which is called a Bowman's lacrimal probe, and you put it inside, right from following the pathway, right from the lower or the upper punctum into the lower and the upper canaliculi, common canaliculi, lacrimal sac, and we right into the NLD and we force it open. Okay, so this probing works, and remember, the earlier it is done. So, suppose you do it in the first 6 months, the lacrimal sac massage has not worked. So, you do it 8 months, maybe repeated 1 year, maybe 1.5 years. The higher rates of success you have if you do it faster, say within a year. But you can try it once or twice, say 1.5 years. But after some time, the valve becomes thickened and you can no longer pop it open by pressing with the probe. Then we do DCR, dacryocysterinostomy, where you open the valve, you make mucosal flaps and connect the lacrimal sac directly to the middle meatus of the nose, because we cannot canalize the NLD further. But DCR is definitive treatment, but is done only after 3 years of age, not before that, because of the growth of the nasal bones must be complete before we attempt that. So in this case, the answer should be clear. It's a 5-year-old boy, so the answer has to be B, which is DCR. If it had been earlier, a newborn, the answer would have been sac massage. 1 or 2 years, we can still try probing, but after 3 years, mostly it is DCR. Very well. This is an important algorithm to do what procedure at what age. Can remember this. Next, which is the most common microbial organism in the normal ocular flora of the conjunctiva? Remember, there's a lot of commensals in the eye, is it not? In the conjunctival sac. This is a conjunctival sac where you're putting the drops here. So what I'm asking is, what is the most common normal microbial organism in the sac? Is Pseudomonas, is it Staphylococcus aureus, Staph epidermidis, and Moraxilla? The answer is, and you should all know, is Staph epidermidis. Very important ocular microbiology question. Remember, the most common commensal in a normal eye is Staph epidermidis. Okay, that is why you often have infections in endophthalmitis. You often have Staph epidermidis infections, particularly in early onset endophthalmitis after cataract surgery. This is the single most common organism in a normal ocular sac, which looks like this. So this is a memory question, a standard question. Staph epidermidis is the single most common. Very well. Which cranial nerve is the most susceptible to damage in increased intraocular pressure? Okay, and that's a very important question. Increased intracranial pressure, intracranial tension. Remember, not intraocular, intracranial. So whenever you have a brain tumor, there's bleeding inside, subarachnoid hemorrhage, non-traumatic ruptures of aneurysms. So there is raised ICT. So which cranial nerve is the most susceptible to damage? Is it the second? Is the third? Is the fourth? Or the sixth? The answer, ladies and gentlemen, is the sixth nerve. And you should all have answered this. Is the abducens nerve. The sixth nerve. Remember, the sixth nerve is a very important nerve for all of us. Okay, it has a lot of peculiarities, and you can see this here. The sixth nerve, remember, is because first of all, it is the second longest cranial nerve in the eye. Is it not? You know that the longest intracranial nerve is the fourth nerve, trochlear, but the second longest is this one, is the sixth nerve, and is the longest. That was, remember, intracranial. This is the longest subarachnoid, or actually not arachnoid. It is the most important. The longest, it is you typically see it into the meningeal nerves, and this is a very, very long nerve. And because of a long course, this long course under the meninges, this gets compressed very easily. And you can see the sixth nerve here. Look at that. The eye is moving here, and this eye should have gone there, but it can only go if the lateral rectus is functional, which is not, because the sixth nerve is paralyzed. So sixth nerve, remember, you have a lot of cranial palsy, raised ICT. And the reason why the sixth nerve gets the most damage is because you see raised ICT, it presses the brainstem down. As it presses the brainstem down, the sixth nerve is passing through Doyle's canal. It is in fact anchored in the Doyle's canal, and the brainstem, as it pushes a little down to the raised ICT, it pulls on the Doyle's canal where the sixth nerve is anchored, pulling it like a plucked guitar string, and the sixth nerve often gets paralyzed. So this is a very important question because it often leads to lateral rectus palsy, which may look to you as a squint, because sixth nerve palsy may appear as a squint. As you can see, this appears as a squint here, but it's not really a squint. The basic pathology is raised ICT. You understand? So this is often called a false localizing signs. Sixth nerve palsy is often called as a false localizing sign of papilledema or raised ICT, because you think it is a squint, but it's actually not squint. It is there because of the raised ICT. Okay, so this is a very important question. Remember, most susceptible damage in raised ICT is the sixth nerve. Well, the next question, what could the reason for a patient who has been wearing contact lenses for 2 years to develop redness, irritation, and foreign body sensation? Remember that. So this patient is wearing lens for a long time. Could be ulcer, bacterial corneal ulcer, could be GPC, giant papillary conjunctivitis, could be fungal keratitis, could be HSV keratitis. So answer here, remember, it could easily be a fungal ulcer or a HSV ulcer or a bacterial ulcer. You remember that the most common corneal ulcer in a patient due to wearing contact lenses is always Pseudomonas. You all know that, Pseudomonas. But you see, this is not a corneal ulcer. Why? Because there is redness, there is irritation, and foreign body sensation, but there is no pain. Remember, the defining symptom of corneal ulcer is pain and loss of vision. Okay, there is no loss of vision, there is no pain here. So it cannot be ulcer. So all the ulcer, bacterial, fungal and herpes simplex virus are ruled out. The answer is GPC, giant papillary conjunctivitis, which is the most common, is one of the most common rather, of side effects of wearing prolonged contact lens. Whereas, look at that, this massive papillae, this giant flat-topped papillae that you can see here, typically a sign of allergy, is most commonly seen in contact lens wear. Okay, so these are called giant because they are bigger than 1 millimeter. Okay, the normal papillae are usually less than 0.3 millimeter. These are more than 1 millimeter. We call them giant, as you can see them like flat cobblestones. GPC is one of the most common side effects of contact lens wear. So because your redness, irritation, foreign body sensation is most likely to be GPC. But we would think of corneal ulcer if the word pain and loss of vision was mentioned. Be careful about this. These are small points, and this changes your answer from 150 to 149 or 148. Which of the following steroids has the highest potential for raising intraocular pressure? And this is a very powerful question. You know that let's look at the choice first, then we'll explain it. The answer is prednisolone, dexamethasone, difluprednate, and luteplon. It's a difficult question. Remember that the basic thing you have to remember is that whenever we put steroids in the eye, whenever it's systemic steroids by mouth or oral steroids, remember the most common ocular side effect is cataracts. But when you have topical steroids, that is by drops, the most common ocular side effect is glaucoma, is it not? So, and you will remember the rule of thumb, the more powerful the steroid, the more the glaucoma, the more the rising intraocular pressure. What do you mean more powerful the steroid? It means simply the more powerful as an anti-inflammatory effect. Okay, as a more powerful anti-inflammatory effect, more that means it can cause anti-inflammatory effect, more it causes raising intraocular pressure. And the answer here is prednisolone incorrect. Dexa incorrect. Remember, Dexa is very powerful, but here we have the big daddy of all the topical steroids. This is difluprednate. This is one of the most powerful anti-inflammatory topical steroids, and it simply has the highest potential for raising intraocular pressure. Remember that most of you, we do not usually talk about difluprednate because it's not a very commonly used steroid. And if I tell you this, if there was no difluprednate in this choice, the answer would be dexamethasone, which is a very powerful steroid. And of these three, this is the most powerful. But because we have this difluprednate, this is the steroid which has the highest potential for raising intraocular pressure, remember, okay? Because simply it has a very powerful ocular anti-inflammatory side effect. So essentially your rule of thumb is more powerful the steroid, more the glaucoma. The answer here is C. If eye has a perforating injury, damage to which eye is the most susceptible to developing sympathetic ophthalmitis? And this should be a standard question. All of you, my friends, you should be able to answer to get immediately. Remember, ciliary body injuries are the highest amount of cause sympathetic ophthalmitis. The maximum chance of developing sympathetic ophthalmitis injury to ciliary body, which is why the ciliary body is often called as the dangerous area of the eye. Dangerous area, sometimes called the dangerous zone of the eye, because injury to the ciliary body leads to the highest amount of sympathetic ophthalmitis. This is a standard question. You cannot make any mistakes with this. Very well. A patient presents with a history of diabetes mellitus of more than 20 years duration, 20 long time, and painless loss of vision. With the given fundus findings, what is the most likely diagnosis? If we look at the fundus here, so we've got diabetes and a very long 20 years and a slow painless loss of vision. If you see what is the diagnosis, is it NPDR, which stands for non-proliferative diabetinopathy, PDR, which stands for proliferative diabetinopathy, CRVO, central retinal venous occlusion, and CRAO, central retinal arterial occlusion. So let's do them one by one out. See, CRAO it is not because there is no cherry red spot here. The diagnostic sign, the definitive sign is a cherry red spot. CRVO it is not because there is no tomato ketchup fundus, there is no splash tomato fundus. PDR it is not proliferative diabetinopathy because you see there are no new blood vessels in the picture. You will, when you see new blood vessels, you will be able to see them like this. Okay, they have delicate fronds, they will be branching, arborizing like this. This is how new blood vessels look like. There is none like this. The answer here is A. It's non-proliferative diabetinopathy simply because there is no proliferating new blood vessel here. You can see the soft exudates, you can see some of them, you can see some of the hemorrhages also here, duodenal broad hemorrhages and soft exudates, but there's simply no new blood vessels, which is why it makes the answer as NPDR. So the answer is the NPDR. However, what is this cause of loss of vision that the patient presents to us with? Now you can understand. Remember, in NPDR, the most common cause of loss of vision is diabetic macular edema, DME. In fact, overall, the most common cause of loss of vision in any diabetic retinopathy is this particular condition called as DME, diabetic macular edema, where you have macular edema or hard exudates around the fovea. Okay, and then 500 microns close to the fovea. If you have either hard exudates or swelling, this DME, the single most common cause of loss of vision in diabetics. So he came to us with DME, but the diagnosis we asked was NPDR. Okay, so that was the question. And with that, ladies and gentlemen, I have to thank you. You must stop me before I keep on going. This is the last time we meet before the exams. So all the very best, my friends, for you. The very best. May you all do very well. Thank you very much and all the best. God bless you.